In today's video, we're talking about whether or not it is necessary to shrink your prostate before receiving prostate cancer treatment. There are different ways to shrink the prostate, whether that's through pills, hormone therapies, or even procedures. And today we're going to talk to Dr. Mark Scholes, who's a 30-year medical oncologist who specialized specifically in prostate cancer. And we're going to talk about these different things, whether or not you need to shrink it, how to shrink it, and what supplements are also available on the market and the effectiveness of them. So in the world of prostate cancer, we're not just dealing with prostate cancer itself, but a lot of times men are dealing with enlarged prostates, and that can cause some other noise with PSA. It can also cause issues sometimes when it comes to treatment. And we did a video a while back with Dr. Moyad and another doctor named Dr. Gange, and it was how to shrink the prostate, and it kind of covered some of the pills that are discussed in that. But when it comes to treatment, is it really necessary to shrink the prostate, in full? So we're going to kind of go over that in the video today. But can you talk about just what happens to the prostate when it is enlarged, what it does to the urethra, and the issues that it can cause?
Having a big prostate is not necessarily a bad thing. The idea that men, as they get older, develop urinary problems, slow urination, getting up at night frequently, is as an inevitability of aging, probably isn't that inaccurate. It's sort of a truism. But one mistake that people make is they assume that it's all about a bigger prostate. It can be sometimes about a bigger prostate, but it doesn't have anything to do with it. It may have to do with bladder wall irritability. Inflammation in the prostate can create symptoms. Just making the prostate smaller is not going to solve all urine issues, and it's also an issue with people who are contemplating treatment with radiation. Men that have really big prostates, some of the radiation therapists appropriately are nervous about radiating a very large gland. Typically they target the whole prostate, and if the prostate gets too big, then you start talking about maybe too much radiation. There'll be collateral damage. So this big prostate, little prostate issue is something that we're thinking about in every client, but from the patient's point of view, just having a big prostate may not really represent a problem. It may be just normal for that individual.
So in some of the articles that I've read, they've talked about shrinking the prostate before treatment in order to get an accurate PSA. So how does that work?
Well, if I think of shrinking the prostate before treatment, to get an accurate PSA, I suppose the reality is that men are on active surveillance. PSA has less weight than it used to now that we've got MRIs and PET scans. So I see the PSA in the monitoring process now more as a fail-safe to make sure that I'm going to be seeing a patient later today whose PSA last year was like 6 and this year was 800. These are rare, kooky cancers that happen. I see one every couple of years. I see hundreds of new cases every year, and one of them will be like this. And that's why we get PSAs. We check them every 6 months in men that are under surveillance because we don't want to get caught with our pants down of someone having a ridiculous growth of cancer in a year and us not addressing that. A real issue for a big prostate in men who are contemplating treatment for prostate cancer is that as the gland gets bigger and bigger, the possibility that it's just too big for the doctor to give a radiation safely. And in those individuals, the conversation does come up about possibly shrinking the gland with hormone therapy or a 5-alpha reductase inhibitor like finasteride or Avodart to make the gland smaller prior to initiating radiation for safety of the patient. The side effects by radiating a smaller target will be fewer side effects compared to a man who has a big target who will risk greater side effects if they want to radiate the whole prostate, which is the typical modus operandi. Sometimes people mistakenly think that they're radiating the tumor. They're actually targeting the whole prostate.
Before I get to my next question, I just wanted to remind you that this September we're having an in-person conference and we'd love to see you there. It's a great way to get your questions answered in person and meet other people in the prostate cancer community. You can learn more at pcri.org. Now, don't forget to subscribe to our YouTube channel. We come out with new prostate cancer videos every week and it's a great way to stay updated. And if you would like to join our cause and donate, you can do so at pcri.org/donate. Now back to my conversation. So what about in situations with focal therapy? I see some patients just have these larger prostates, they want to get focal therapy, and they're concerned and being told that because they have a larger prostate that they are not candidates for focal.
Right. Well, I think it's entirely the opposite. Men who have small prostates are the ones I feel that are facing the greatest challenge for doing focal therapy. If there's a spot in the prostate, the doctors are going to want to put a margin of safety in the radiation field or the HIFU field or the electroporation field around that lesion to make sure that they get it all. And we don't want to be dealing with it coming back sometime in the future. So if you put a margin of treatment around the spot and the gland is really small, it's quite possible you'll end up treating the whole prostate. Men that have big prostates are usually those that set up best for doing focal therapy because there's plenty of normal prostate tissue around the lesion, around the cancer, and that if you put a margin around it, you're still only treating a small percentage of the gland, and you're less likely to incur side effects, particularly erectile dysfunction, in men who have focal treatment in a big prostate rather than a small prostate. So the only time I get concerned about a prostate being too big for radiation is if the doctors are planning to treat the whole gland, which is the normal mainstream way to treat prostate cancer, is they target the prostate with a 3 to 5 millimeter margin around the perimeter, and that's how they make sure that they get it all. They're not targeting the tumor. So big prostates become an issue for whole prostate therapy. Big prostates are preferable in men that want to do focal therapy.
So what about in situations with brachytherapy? Does a big prostate affect that at all?
Yes. So I tend to think of brachytherapy, proton therapy, SBRT, IMRT, CyberKnife as radiation. There really are very few differences in terms of potential toxicity with any of these measures. So big prostates are going to be an issue with radiation. What is a big prostate? Well, you talk to different doctors. They're talking about something, if the prostate is twice as big, maybe that can be handled. Normal is about 40 cubic centimeters, and 80 cubic centimeters can state-of-the-art centers radiate an 80 cc gland? And the answer is they can. You start getting up to 100 cc's, 120 cc's. Now we're getting into a realm where they may talk about administering some kind of hormone blockade medicine to shrink the prostate and to make the target smaller for men that want to do whole prostate therapy.
So when we talk about 5-alpha reductase inhibitors, what are those kind of in layman language? Is it over the counter? And what would be the context in which someone would be prescribed that medicine?
Right, so those medicines were originally FDA approved for men who have urinary problems because they will shrink the prostate volume to some degree, and certain individuals it'll improve urine flow. These are medicines like finasteride, otherwise known as Proscar, or Avodart, otherwise known as dutasteride. Utilization of these medicines prior to radiation to shrink the prostate probably is not as common as more standard hormone blockade agents like Orgovyx, Lupron, Eligard, because often with men with intermediate or high-risk disease, they're also getting hormone therapy to improve local control rates if they're having beam radiation, or even to improve cure rates if they're having radiation to the surrounding lymph nodes. So intermediate risk, the traditional approach is to give 4 to 6 months of Orgovyx or Lupron, and in the high-risk patients, the traditional approach is to give 18 months. The radiation treatment can be started at any time, and you'll see maximum shrinkage of the prostate probably after 2 to 3 months of Orgovyx or Lupron. And the radiation therapists appreciate that. If the gland shrinks 30%, you have a 100 cc prostate and it goes down to 70 cc's, that individual's less likely to have lasting long-term radiation-induced side effects. Probably reasonable to mention here about prostox in this context as well, because all of this talk about shrinking the prostate prior to radiation for whole prostate radiation is related to long-term side effects. Short-term side effects are common and typically will blow over in 4 to 6 to 8 weeks after the treatment is completed. But long-term side effects, where people have lingering urinary problems for years afterwards, seem to be rooted in genetic deficiencies that a small percentage of the normal population has. And now there is technology that can detect that, called Prostox from a company called Miradex. This can parse out the people who seem to have that deficiency, and then they can alter their treatment plans based on those results.
So going back to finasteride or Avodart, do those have side effects?
Finasteride and Avodart clearly can have side effects, most prominent ones being reduced sex drive and reduction in semen volume when men have orgasms. Those are the two primary downsides. These medicines in low doses are also FDA approved to help men that have had hair loss of aging, as it will reinduce hair growth in certain individuals. But the side effects for loss of semen volume and reduced libido are reversible if the medicine is stopped in a timely fashion. If it's continued for years and years, it's possible that those side effects could remain permanent.
And how long would someone be on those types of medications in order to shrink the prostate? Like, how long would it take?
Well, if someone was implementing these medicines merely to reduce prostate volume prior to radiation, and they're not doing the more traditional Orgovyx, Lupron type medications, I would think that they're going to get a maximum benefit in about 60 to 90 days.
So with the hormone therapies like Orgovyx or Lupron, we do see the side effects of hormone therapy, which there's quite a list. Can you go over that list really quick and then kind of talk about the duration of how long someone would need to be on hormone therapy in order to achieve the shrinking results that they need in order to receive the radiation?
Well, I think that duration is about the same as it is with 5-alpha reductase inhibitors, maybe about 2 to 3 months. But the other side effects, which can be very notable, are usually complete loss of libido and loss of muscle, which is associated with fatigue, and a real propensity for weight gain. There's some other side effects as well, but those are the big three problems. And this is, in my mind, being reconsidered now because intermediate risk, 4 to 6 months, as I said before, high risk, 18 to 24 months. So this policy, in my mind, has been reconsidered now that we have PSMA PET scans that help us have a greater degree of confidence that nothing has already spread outside. In the past, we didn't have that confidence, and as a precaution, we would use these medicines really without any second thought. It was just considered routine. I don't think that that policy really holds up now that we have PET scans that can give you 80 to 90% confidence that there are no metastases. And in those individuals with negative PSMA PET scans, the value or the improvement in cure rates is going to be diminished because of the fact that we know in the majority of these men that they don't have any spread.
When we talk about Lupron versus Orgovyx, does the recovery of testosterone and sex drive, is it better for one than the other?
Yeah, there's a clear advantage for Orgovyx. Recovery of testosterone after Lupron is stopped is often quite postponed, and sometimes these men will never re-establish their baseline testosterone levels. We don't have all the information yet in terms of Orgovyx recovery. It's a much newer medicine, but there's no doubt that testosterone levels recover substantially quicker than in men who have been on Lupron.
So do you have patients who come in your office and would really want to go for something like finasteride or Avodart because they don't want to go through hormone therapy? Do they tend to prefer this? Or is that really the first, measure that you would take and then you would go to hormone therapy if it doesn't work?
Well, we're talking about a fairly small group. So we take a man who has a big prostate, has, say, recently diagnosed prostate cancer, but is thinking about having definitive whole prostate radiation. Let's say he has a 100 cc prostate. Because traditionally intermediate risk patients, we don't treat low risk patients anymore, but because traditionally intermediate risk patients were all getting 4 to 6 months of Orgovyx or Lupron or Firmagon or one of these agents, utilization of 5-alpha reductase inhibitors as a preamble to radiation is not talked about very much. Is it a feasible consideration in men that have a big prostate and want to not endure the known side effects of Orgovyx, the total loss of libido, loss of muscle, all these sorts of things? Certainly it's a reasonable consideration. I don't run into that particular scenario very often, but it's plausible to use a less toxic medicine like finasteride or Avodart when you have that option.
What about men who are, considering surgery? Would a large prostate be an issue for those men?
I think it's a very good question because the historical approach to men with large prostates was to lean towards doing surgery because not only did you treat the cancer, but you also treat the often accompanying urinary symptoms that go with big prostates. The removal of the prostate improves urine flow, sometimes too much, and men end up with incontinence and whatnot. But that policy for men with really large prostates was often in an era where we didn't do focal therapy, was oftentimes considered the only approach, was to do surgery. Another comment about surgery is men are often told that in comparing surgery and radiation, that, and we're talking about beam radiation, that they can forego hormone treatment if they do surgery, which makes surgery sound attractive. Hormone treatment has a number of side effects. The policy of always giving hormone therapy with radiation is really in the domain of beam radiation. The beam radiation doctors have to give a somewhat attenuated dose of radiation to avoid side effects and to augment cure rates. The hormone therapy synergizes with the radiation in the prostate and brings the cure rates up to match that of surgery. It turns out with seed implant radiation, where they can give a bigger dose because you're not beaming the radiation through healthy tissue, men often can forego the hormone therapy altogether. And people question that, but they're forgetting the fact that with surgery, which is just another way to remove the primary tumor, hormone therapy is usually only administered to men who have a relapse at some point. Hormone therapy is not given at the same time as surgery as a general rule, especially now in the era of PSMA PET scans that helps us have greater confidence that there's nothing spread. The logic of doing a radiation treatment without hormone therapy, that offers men a much better quality of life. The old mantra that you always have to do radiation with hormone therapy, I think, especially with seed implant radiation, is simply not true.
In our previous Men's Health Conference, we had Dr. Brian Helfand talking about BPH, and you guys really, with you and Dr. Moya, did an incredible job categorizing these types of treatments for patients. You have 5 alpha reductase inhibitors, you have hormone therapies, and then you go into procedures. And a lot of times when we think about, shrinking the prostate, I think a lot of times because patients don't realize that the other treatments are available, procedures are the first thing we go to. So do men ever choose to do BPH procedures before they would get treatment in order to be eligible for radiation?
Definitely. This opens up a very important consideration in men that do radiation, because the surgeons always talk down about radiation. They say, well, you may have less upfront side effects. You don't have to have a catheter, and you don't have to have incisions, and you don't have to, go through general anesthesia and all these sorts of things. But radiation will have a cumulative effect over a lifetime, and you'll come back someday with some really difficult problem. And of course, I think anything's possible, and especially if you're not going to a state-of-the-art center, side effects are certainly a potential outcome, just as you can have bad side effects with a bad surgeon. The same problem. All that being said, there's also a reality that after the prostate is radiated, just after any human tissue is radiated, they push the dose of radiation for the normal tissues right up to the limit. And so those tissues, in this case the prostate, will always be somewhat more fragile for the rest of your life. If someone like that needs to have a procedure where they go in and carve out the middle of the gland to improve urine flow, there's always a danger that the healing after that procedure will not be ideal. As a result, men that are contemplating doing radiation now, if they have kind of sketchy pre-existing urinary symptoms in the present tense, the radiation actually over time might make that better. But if they get into a situation where they have to have a transurethral resection or an aquablation where tissue is removed, there's a greater danger of complications. And it's not unreasonable to talk to a urologist prior to the radiation in men that are struggling already in this area about having a transurethral resection or an aquablation before the radiation, when the tissue will heal normally, and then doing the radiation after the problem is fixed.
So another question we get is, are there supplements that can shrink the size of the prostate?
Not that I'm aware of, although there are things like saw palmetto where they argue that it will make the prostate smaller. Saw palmetto, to the best of my understanding, works a little bit more like an alpha blocker. These medicines, not a 5-alpha reductase inhibitor, but an alpha blocker like Flomax, Rapaflo, Uroxetrol. These relax the urethra, the muscles in the urethral wall, and improve urination that way. But aside from the possibility that saw palmetto has enough activity to justify, the other supplements that might be of some use are not going to shrink the prostate. Some of them may have a modest anti-inflammatory effect. Prostatitis is another thing that mimics urinary symptoms, just inflammation in the prostate. Very common for men. It doesn't usually turn into serious problems. It can be uncomfortable, and it can induce, nighttime urination or urinary frequency. but it's not a dangerous thing. It's just more of an inconvenience. And sometimes these over-the-counter anti-inflammatories will have a modest benefit, but none of them really you could argue are able to shrink the prostate.
If you have a large prostate, this is just another factor to bring up to your physician and ask him, if I'm going to have focal therapy, is my enlarged prostate beneficial, as Dr. Scholes mentioned? Or if you're seeking other forms of radiation where it is whole gland, do you need to shrink your prostate? And what I would talk to your doctor about is what is the least amount of treatment for the greatest benefit, and go in the order in which Dr. Scholes mentioned. Now, as far as supplements go, Dr. Curtis Nickel from a previous Men's Health conference did a great talk on saw palmetto, and we'll link that in the description below this video. We'll also put it in our comment section. He goes through what saw palmetto is, how it affects the prostate, and what the clinical trials talked about. And really, with those results, you can talk to your doctor and see, hey, is this something that should be added to my treatment regimen? We also know about quercetin, and you can do some research. A great way to find out really about supplements is to look at our Men's Health conferences. And in our previous Men's Health conference just here in 2024, Dr. Mark Moyad talked about Costco and how that's a really great way to get supplements from Costco because they do a great job with their sources and you know what you're getting. All of this information is available on our website at pcri.org. Now, if you would like help with your particular case, you can contact our helpline at pcri.org/helpline. They give you information, not advice, but they've been through the prostate cancer journey. They have a wealth of information, and it's a great way to get ready for your doctor's appointments. Please reach out if you need help, and you can find out more information again at our website at pcri.org. Most of all, please remember, you're not alone, and I hope you have a great week.